Hey, this is a presentation on inadvertent perioperative hypothermia, and the subtitle there is definition for perioperative hypothermia. Basically, a patient's core temperature drops below 36 degrees Celsius. So the question is then, how do we assess a patient's core temperature? In my opinion, and in the opinion of many others, when you have an indwelling catheter and a thermometer attached to that, give you a very good indication of core temperature. A second method would be to put a temperature probe into the esophagus, but the probe often sits next to a tube, an endotracheal tube that is, which has cold air in it, which may affect the reading of the temperature. So best assessment of core temperature would be, in my opinion, the temperature probe attached to an indwelling catheter. In the recovery room, there's no such opportunity, so we use the tympanic temperature thermometers. These tympanic thermometers are very iffy. I've been involved in many experiments where we tried out different thermometers, and with different people, all on the same patient, we all got different readouts. So then we were left with what is the right temperature and what's not. So in the recovery room, you can communicate with your patient and make sure they feel comfortable. You can feel the skin and get a reasonable idea, besides taking the tympanic temperature as well. And I think everyone knows that our discharge criteria in the recovery rooms is 35.5 degrees Celsius, not 36. But in all of the literature, the definition that a patient's core temperature lower than 36 degrees Celsius is defined as hypothermia. All right, let's delve in. Why is this also important? So there are some possible adverse outcomes of perioperative hypothermia. One of it is delayed wound healing, because when you're cold, circulation shuts down to preserve core temperatures, and important nutrients for healing, oxygen and glucose for energy, cannot reach the wound site, and there is a documented delayed wound healing response possible. Now, same applies for the circulation effects on the immune response, and there will be a decreased immune response because of poor circulation, perhaps leading to increased infection rates. Increased blood loss when the core temperature drops to in the 34s. Blood doesn't clot very well, and for example, in the case of postpartum hemorrhage, we now have the necessity of forced air warm blankets to be available to make sure temperatures do not drop and cause more bleeding problems than we already have. So consequently, patients will not be discharged timely, so there's an increased length of hospital stay. Patient might feel discomfort and may be less satisfied or even dissatisfied. Increased likelihood of cardiac arrhythmias to do with levels of potassium. And there's altered metabolism of certain drugs such as rocuronium and vecuronium. So in recovery rooms, people may be breathing very shallowly, or in a shallow fashion, that's maybe better English, because I slowed down metabolism in the liver of these two neuromuscular blockers, rocuronium and vecuronium. So how then should we deal with perioperative hypothermia? And the best remedy is prevention. So the evidence suggests that preventing or limiting the first state of heat loss is the key to tackling inadvertent perioperative hypothermia. So ACON has a big documented evidence on the best practice, and I've just taken out a few of these. The whole standard on hypothermia is a bit too lengthy, but I've taken out some important points. So first of all, the criteria for identifying known risk factors. So the ASA, grade 2 to 5, you can ask your anaesthetist. Plan to combine general and regional anesthesia, major surgery, a known risk of cardiovascular complication, kids and older adults, hypothyroidism, surgery involving general, regional, neuraxial anesthesia with an expected duration of longer than 30 minutes. So 30 minutes seems to be the criteria there. And preoperative baseline temperatures of less than 36 within the hour prior to surgery. And there's some further discussion points on that, but I thought not to overload you too much. But this is just, so you know, like, is there a good reason maybe to pre-warm a patient? If the procedure is 30 minutes or longer, yes. If the patient is hypothermic already, yes. All right, let's look at some other ACON best practice points. So here, healthcare providers caring for perioperative patients have a duty to monitor and document temperature at the following intervals: within the hour prior to transfer to the perioperative department, on arrival to the pre-op area, immediately preceding induction of anesthesia every 15 minutes when forced air warming is used, every 30 minutes for all patients on admission to PACU, and then every 15 minutes thereafter. I'm proud to make a decision regarding ready for discharge from the recovery, and actually also upon the time of discharge. All right, moving on to the next lot of criteria. So, where clinically feasible, active warming strategies should be commenced prior to surgery as soon as possible for patients with baseline preoperative temperatures of less than 36 degrees Celsius and or thermal discomfort. So active warming strategies are the warming of IV fluids to at least 36, the warming of intraoperative fluids to about 38, 40 degrees, using forced air warming blankets, and having the operating room temperatures between 20 and 22. In particular, before induction, the temperature should be 21. Here it is. Ambient temperature should be maintained at 20 to 22, but should be at least 21 while the patient is exposed during the intraoperative period. Provide adequate coverings. So particularly the head is designed to disperse heat, so a nice small blanket around the scalp could help preventing perioperative hypothermia. Some further best practices. So I mentioned it before, intravenous fluids of 500 ml or more, including blood products, should be warmed to 37 using an appropriate warming device. Irrigation fluids between 38 and 40 degrees Celsius. Forced air warming should be used for all patients with expected duration of anesthesia longer than 30 minutes. Okay. And here we are to our sixth list of criteria. Perioperative nurses caring for patients in the recovery rooms have a duty to monitor and document temperature on arrival, and then every 15 minutes thereafter. Implement active warming strategies for patients with temperatures less than 36 degrees. Document the use of these strategies. Include temperature monitoring as part of the assessment of readiness for discharge from recovery. And not transfer patients whose temperature is less than 36 degrees to ward areas. So 6.4 and 6.5 here at the MARTA, we actually say 35.5. And I believe a lot has to do with the use of tympanic temperature probes. They should actually touch the tympanic membrane, but in many occasions this is not possible or doesn't happen, or it's too uncomfortable for the patients, meaning that the readout is questionable. All right, thanks for your attention. I hope that cleared up some of the rules around preventing and treating hypothermia, the most earliest of stages. Thank you.